Okay, guys, you can see the pressure injury risk assessment tool there.
Yes.
Awesome.
Yes.
Okay, so today I'll be doing my presentation on the pressure injury risk assessment tool. A little bit of who I am. My name's Kate. I've been a registered nurse for the last 10 years. Over the last 2 years, I've been working as an agency nurse in rural and remote places all over the country. I've worked in hospital settings and aged care facilities. So just at the start, if you guys could just make sure you're minimizing the risk around you, whether it be cords, making sure you're sitting up straight on your chair so you won't fall off. And do both of you know where your nearest fire exit is?
That way. Yes.
Or exit in general? Everybody's feeling safe there.
Yeah, I have a terrible chair that I must replace soon. But I'm
That
working
might
on
be
that.
your push to do it, Bev.
I think it will be.
So today we're going to learn about the pressure injury risk assessment tool and how it's filled out and used in the hospital setting. So the objective is for you to become familiar with the form and understand some of the interventions that we can put in place to decrease the risk of pressure injuries in a hospital setting. So a pressure injury risk assessment is a tool used to quickly identify when there is a risk of injury to the skin. By identifying the risk, interventions can be put in place for the best patient outcomes. So the Braden scale is the most commonly used skin assessment tool. And it's the one that I'm most familiar with. It is a legal document. And the learner, I know you haven't received it, Bev, but I did send it to Judith and Jackie. Received the pressure injury risk assessment to their emails for reference and a little bit of breakdown of what we're doing today. So what is a pressure injury? So a pressure injury is a localized injury to the skin and or the underlying tissue, usually over a bony prominence as a result of a pressure or pressure in combination with a shear and or friction. So this hospital complication includes the diagnosis of different stage pressure injuries. I have seen patients who have come in from home with a pressure injury as well.
Can I ask a question?
Yeah, of course.
What is shear?
So a friction or shear, I'll just exit so I can see you guys. Say when you have an elderly patient who is not very mobile and have you seen someone use slide sheets before?
Yeah.
So it could be from slide sheets when you're moving a patient up the bed, could be from
Okay.
clothing, could be from a bed sheet.
Yep.
Because of the particular manual handling that everybody should do, you should have two slide sheets on top of each other. Some people just use one slide sheet and fold it in half. Some people use the actual bed sheet and pull the patient up, which you definitely should not do. So that's basically what a friction or from a shear was usually from a bed sheet. So people not using basically the right manual handling techniques.
Yep.
You guys can see my screen still.
Yes.
So the stages of a pressure injury. So there's 4 stages. So we have stage 1, a red, blue, or purplish area first appears on the skin like a bruise, may feel warm to touch. Stage 2, the bruise becomes more open, sore looks like an abrasion or a blister. And the skin around the wound can be discolored and it can be painful as well. Sometimes I find usually the sacrum, like the backside, the bony prominence, basically between your butt cheeks, is a high risk area. Heels as well as toes, when you've got heavy sheets of blanket sitting on toes as well, are very high risk areas. So the sore deepens and looks like a crater, often with dark patches of skin around the edges. The damage extends to the muscle, bone, or joints and can cause a serious infection of the bone known as osteomyelitis. It is also led to potentially life-threatening infection of the blood called sepsis. So the way that we basically assess a pressure injury is if you have a reddened area, whether it's here or sacrum, wherever it is, usually a bony prominence, you just put your finger on it like that. And you see if there's basically a blood return to it. So when you basically check your capillaries, you just give a little press. Does the color come back into it? If it doesn't, that's when you know it is a pressure injury. So you can do it to yourself now, wherever. Do you have blood return? If you don't and it stays red, you know that that's a pressure injury and there's been some damage done. Any questions so far, guys?
I'm a little bit scared. I think this is my future.
I hope it's not, Bev. I hope it's not, but
Oh,
that's why
so
we
do
have
I.
these assessments in place.
Yeah, it's important, isn't it?
Very, very important, unfortunately, with the elderly. So this is a quick snapshot of the Braden risk assessment tool to the left here. So this is our assessment. And these are the interventions that we put in place. So are they mild risk? Are they moderate? Are they high risk? Or are they very high? So with this assessment tool, you have to do a pressure injury risk assessment or a Braden, depending on the placement facility that you're in, on every adult patient. So no matter their mobility status, everybody needs one. So this tool, as I said, is used on every admitted patient to the hospital. It needs to be done once they've decided that the patient will be admitted. You've got 8 hours to do this paperwork. It's updated on the transfer to a new ward. It's also updated post a new pressure injury in the hospital setting. So if you have done a pressure injury risk assessment and, someone has had, low risk, but then they've developed a pressure injury, you need to redo your Braden, and obviously they're going to be more higher risk and possibly more interventions that need to be put in place so it doesn't worsen or they don't get another pressure injury. So any medical condition or change which would change their mobility status and their ability to attend to their own pressure area care, such as moving in the chair or their bed. So say, patient has had a fall. Previous to this, they've been independent with their mobility. They were able to move around. Now they've got a broken hip. Obviously, they're going to be a higher risk of a pressure injury. So you need to redo their pressure injury risk assessment form. And possibly put some new interventions in place.
I have a question.
Yes.
So you know how people are in wheelchairs? Are people in wheelchairs more likely to have these sores?
Definitely. Yeah. So obviously sitting for a long time, and depending on why they're in the wheelchair, whether they're, say a paraplegic or quadriplegic, do they have any sensation as well, is a really high risk factor, because if they don't have any sensation, they don't feel the soreness, they don't feel the pain, and the wound can break down really, really quickly, rather than if someone's in a wheelchair because of, lack of mobility, but they still have the sensation, at least they're like, oh, my backside's a little bit sore. There's obviously something going on there. So then we can be kind of alerted a little bit quicker.
Yeah. Thanks.
So I'll just go back to the statistics here. So each year, patients in Australia experience a large number of pressure injuries, with 4,313 pressure injuries occurring in Australian public hospitals in 2015 to 2016, which is huge. The rate of hospital-acquired pressure injuries in Australia was 9.7 injuries per 1,000 hospitalisations. When you think about it, that's a pretty high risk and pretty high percentage. Hospital, yeah, it's huge. You'll be surprised the amount of pressure injuries that you have in the hospital. Huge amount. Hospital-acquired pressure injuries extend the length of hospitalisation, which impacts on patients, their families. These injuries also increase the cost of admission incurred by the health service. This additional cost may be the result of an increased length of stay or more complex care requirements. Say if a patient, would usually just go home after their admission, but now they've got a pressure injury. So they have, when they go home, now they need, you know, a nurse to come and dress their wounds and things like that as well for a significant amount of time. So now we're going to do a demonstration. So for the first example, I'm just going to put some time there. My patient is an 80-year-old female. They've had a fall at home. They've broken their hip and they're unable to mobilise independently. And Jackie and Bev's patient, yours is a 50-year-old female coming to the hospital, lower abdomen pain, usually runs 10 kilometres per week and is able to mobilise independently.
Okay.
So I'll just get my form up so I can do mine and then I'll work through yours with you guys together.
Hey, do you
Any
think
questions so far? Sorry.
well, I've got a question for you now.
Yeah.
Do you think that the as a nation we're getting bigger and heavier, and that's going to
That's a good
lead
point, yeah.
to like decreased mobility? Is that going to increase the risk here?
It will have different risks. For pressure injuries, maybe not as much, because pressure injuries are usually on a bony prominence. So if you've
Good
got a
points,
patient
yeah.
who is a lot bigger,
Yeah.
they won't be, it won't be, you know, skin, muscle, bone onto the bed, which usually, or hard
Yeah.
surface, which gives them the pressure injury. But if they are bigger, they're going to have other health issues, you know, which may be cardiac,
Yep.
mobility, then, you know, their kind of joints may give way, hip, knees, all of that type of stuff, if they are a lot bigger and not exercising as much as well. So it could go either way.
Yeah.
It's usually the
Interesting.
older ones that are the higher risk of the pressure injuries, because they, unfortunately, as they get older, they're losing their appetite, they're not eating well, sometimes, you know, just skin and bone. So and you guys can see that clearly.
Not
Pressure,
yet, but
hopefully soon.
it says you've started
Maybe
screen sharing.
Maybe I'll change.
Yeah. Yeah, I know. I think sometimes it's tricky doing the online presentations with the technology. I'm not always that good at it.
Has that come up?
No, I can only see you.
Oh.
If the screen, your screen sharing is
stop.
paused.
I'll stop share. And I'll go again.
Yep.
Any luck?
Now I've got it.
Yeah, I
Yep.
can see it.
Got
Yeah,
it?
I've got it. Yeah.
Cool.
Yeah.
Perfect. So this is a Braden risk assessment tool. So we're going to, for this example, use my patient. I'm just checking time there. So we'll start with sensory perception, ability to respond meaningfully to pressure-related discomfort. So my patient, what were they, 80 years old, that had a fall at home. Now they've got a broken hip. Unresponsive to painful stimuli. I would say no to that. Responds only to painful stimuli, cannot communicate discomfort. I would say no to that, because they are alert and they can respond to verbal commands, but can't always communicate discomfort or need to be turned. So to relieve the pressure injury is when we do pressure area care, so rolling the patient from side to side, popping them up on their side, propping some pillows underneath to basically take the pressure off their sacrum, which is their backside really. So I would say slightly limited. Sorry. Don't mind my circles, guys. And then we'll move down to mobility, ability to change and maintain own position, where they're going to have some limitation because obviously they've broken their hip, pain, discomfort, all of those type of things. So they're not completely immobile. Very limited, makes occasional slight changes in body or extremity position, but unable to make frequent or significant changes independently. I would say they're very limited. So we'll go 2 for there. And then at the end, we'll add up the scores. So these 3 lines here are just the different dates of assessment. And activity. So degree of physical activity. Are they bed fast? Are they confined to the bed? Are they chair fast? Ability to walk severely limited or non-existent? Walks occasionally during the day. They've just broken their hip. Realistically, they're not going to be walking during the day. So let's say 2. Somehow I'm doing shapes, but anyway, let's just roll with that. And then we've got moisture. So degree to which the skin is exposed to moisture, constantly moist. So skin is kept moist by perspiration, urine, drainage, dampness is detected every time patient is moved or turned. If someone's really incontinent, even if they do have a pad on, whether it be urine or feces, that's another risk of them getting a pressure injury. If you've got moisture on the skin and pressure on the skin, that skin is going to break down a lot quicker. So let's say for this sake that we say that the patient is continent, so they don't have to wear a pad. So in this instance, we'll just say skin is usually dry. Linen only requires changing every 24 hours. And then we've got friction or shear. So problem requires moderate to maximum assistance in moving. Complete lifting without sliding against sheets is impossible. Frequently slides down in the bed or the chair. Potential problem, moves freely or requires minimal assistance. During a move, skin probably slides to some extent against the sheets, chair, resistant to other devices. I would say this is probably a problem with this patient, just because of the, I don't know what I've done there. Let's just get rid of that. Let's see what we can do. There we go. And then nutrition. So very poor, so nil, poor oral intake, maintained on clear fluids or IVs. Even though they've broken their hip, they can still eat. Inadequate is on a liquid diet or tube feeding, which is not relevant here. Adequate is on tube feeding or eats over half of most meals. So let's say it's adequate, but it's not going to be excellent. Realistically, an 80-year-old is probably not eating adequate nutrition. So any questions so far?
Oh, that's a great table, isn't it?
Yeah.
Great tool.
I've probably done these a few thousand times, I reckon, Bev, in the hospital.
How'd you do?
So we have to do them on every patient that's admitted.
Gee, there's a lot of paperwork because you were telling me last week.
I've got paperwork coming out of my ears. I've got so much of it. So what I'm going to do, I'm going to add up the score, and then that will give us the risk, and then we're going to move to the interventions that we can put in place for this patient. So their score is 15.
So that means that they're a mild risk, is that right?
Oh, I don't think I'd do that. Yes, correct. I don't know if I'll be able to write 15 here. How about we do a text box? And just because it's 15 now doesn't mean it will be 15 in an hour. So it can always change.
So how often would you do these forms, okay?
So if the patient gets a pressure injury, you have to redo it, change of ward. have to redo it. Every 7 days, if there's no changes in between. And change in mobility as well will obviously change this. So we've got score 15. So they are a mild risk, score 15. So these are the interventions that we are going to put in place for this patient. So frequent turning and repositioning as appropriate, maximum remobilization, get patient moving. That's more of a post-op thing with this patient. You can only do, so much moving with someone who's got a broken hip. Pressure reduction support service if bed fast or chair fast. So if they are rest in bed or a patient in a wheelchair. Protect the heels. So a few things that we can do is we can basically put a pillow under the knee. This is the patient's foot, and this is the patient's foot here. You want the patient's feet basically hanging over the pillow. So you've got about this much area between the heel and the bed, so it's not, pushing on the pressure. Manage moisture. So that's when, say, the patient is incontinent. Are they bleeding? Are they vomiting? Loose bowels, anything like that. Manage nutrition. Refer them to the dietitian. Do they need, some supplements? Do they need a high protein, high energy diet? Manage friction and shear. If they're sliding down the bed heaps, make sure you have a bend in the knee of the bed. So then, they're kind of working against gravity, so they're not sliding down the bed constantly, sliding down the bed, and then you're having to slide them back up constantly. If other major risk factors are present, advanced age, poor dietary intake, blood pressure below 60, hemodynamically instability, and advance to the next level of interventions. So even though they're scoring 15, if you feel like they do have other risk factors, you can move them down to the moderate one as well. So let's say for this instance that you're like, yep, patient is an advanced age. Let's put some more interventions in place. Frequent turning at least every 2 hours. So you're going from backside, side to side every 2 hours. Using foam wedges, not really common anymore. Usually just use pillows. Pressure reduction, support surface, maximal mobilization depending on what the patient's in for. Protect heels, manage moisture, nutrition, manage friction and shear. It'd be more so popping in a turning schedule. It's usually every 4 hours, but depending on the patient, if they're palliative or if they've got a lot of pain, every 2 hours sometimes is not really suitable. Sometimes more than 4 hours. Some people need pain relief before you turn them. So, getting a plan in place with the doctors as well, making sure they've got enough pain relief, make sure it's fast acting before we need to turn them as well. Any questions so far?
It seems like a great framework, doesn't it?
Yeah, no, it is good.
Good. Yeah.
So I'm just going to stop sharing and then I'm just going to get up. Cannot minimize, no worries. So we'll work together and do your assessment tool of your patient. So I've given you your little case study. You guys are happy with that?
Yes.
Yeah.
Great example.
So it's the same example that I used last week with Jackie. So she'll be familiar with our lady.
Yes. She runs 10Ks a week. Yep.
Yeah, she's a fit lady.
Yeah.
Are you
Gonna
guys?
say, has she improved since last week, Jackie?
No, she's the same. She's
She's the same, yeah.
So all
Poor
these
lady.
interventions have been useless.
I know. Southwest Healthcare, bloody hell, get your act together.
Oh dear.
Can you guys see this Bahrain risk
yeah.
assessment
So
tool?
in terms, does our lady have a name, Kate?
Here we go.
Yes,
I can see
it is Judith, who isn't here.
So Judith.
Righto.
Hmm,
So Jackie, do you want to do the first one? So sensory.
yeah. Sensory perception ability to respond meaningfully to pressure. So I think that she would respond to pressure. So I'd probably just say no impairment, number 4.
Yeah, I would say that as well. And Bev, if you want to do mobility, so ability to change and maintain own position, do you think she would have any limitations?
Well, she hasn't broken anything. She's fit. She's a lot younger. I would say no limitations.
Yeah, definitely. Jackie, activity, degree of physical activity.
So she is running 10 kilometers a week, so she would walk frequently.
Mm-hmm.
Running laps around the ward.
Yeah, exactly. And that's, even if, patients come in with some type of ailment, even if they are mobilizing, that's going to decrease their risk of chest infection and things like that. So even though when you get in the hospital, they probably just want to rest, but where they're telling them to do their deep breathing exercises and try and take a walk around the ward, sometimes it's the last thing people want to do, but there is a reason for it as well. And Jackie, moisture, degree to which skin is exposed to moisture.
Yeah, rarely moist. Skin is usually dry.
Yeah. It's going to go weird on me again. Let's try that again. Beautiful. And friction and shear.
She's certainly not going to need assistance. She's not moving feebly. She'd have enough muscle strength to lift, so I'd say no apparent problem.
Yeah, I would say that as well.
I could be a nurse.
Oh, you practically are, Bev. Look at you go. And Jackie, nutrition, what would you say?
Nutrition, I'd say adequate. I'd say excellent.
Perfect. So she is going to get a mild risk score. She's scoring the highest for all of them. So mild risks, we've gone through these. Protect heals, manage moisture, manage nutrition, manage friction and shear, pressure reduction support surface, get the patient moving, which she's walking around the ward and doing all the right things. So,
what if the managing moisture thing is impacted by her lower abdominal pain?
The managing moisture, I guess, interventions that you could put in place is a toileting plan. So say if she did have some issues managing moisture, that's okay. Just putting interventions in place would be ideal for her. Any questions at the minute, guys?
No, it was excellent. Thank you, Kate.
I think you've done a great job.
All right, I think my time might be up in 30 seconds. So
You've timed that beautifully then.
Any questions as such or any feedback that you would like to give me?
I liked it. I thought it was really good. Yeah.
I'm going to pick your brains about Canva too.
Oh, yeah. Okay.
Yeah, it looks better than PowerPoint.
Oh, it's so easy to use. I'll stop this shortly, but I'm not quite at the 30 minutes. I've got a few seconds to go. Okay, I think I can stop it now.